Hello, I'm David R. Jones of the Community Service Society. This episode of the Urban Agenda is the first of a very special two-part program examining managed health care. 43 million Americans have no health insurance at all, and many of those who do, through government programs like Medicare or their employers, are now receiving health services through managed care programs. Managed care is complicated, and understanding how it works is essential, especially when your health is at stake. In addition to a very interested studio audience, I'm joined today by two managed care experts. Chris Molnar is the director of the Managed Care Consumer Assistance Program, which is based at the CSS offices and provides training and grants to community-based organizations. And Joe Baker is the executive vice president of the Medicare Rights Center, an advocacy organization working on behalf of Medicare beneficiaries. Welcome, both of you, to the Urban Agenda.
Thank you.
Well, Chris, why don't you describe to our audience what in the world is managed care in the first place?
What in the world? Managed care is different than what we consider traditional health care, namely for three main reasons. One, when you join a managed care plan, you're restricted to which doctors, hospitals, physicians you can use, and that's called a network. And every plan has a book of providers, but more important than that, it's also how you access specialty care. You need a referral. It's a very different way of getting health care, going to a primary doctor, getting a referral, and getting those services. And lastly, a very big issue for most people is what's called a formulary, which is which drugs are actually on the list and covered under the health plan. So it's a very different way of allocating services.
Joe, tell us, there are managed care plans for Medicare recipients. Why in the world would a Medicare recipient want to sign up with managed care?
Well, people with Medicare, as you know, are 65 plus or people with disabilities. And many people with Medicare are looking to the Medicare HMOs to get additional benefits and lower costs than they might be able to get in the government-run original Medicare program. For example, Medicare HMOs pay for prescription drugs. It's a limited benefit, but for many people with Medicare, it's a great deal. As well, there are lower costs. The co-pays and other costs that are available in the Medicare HMO can be less than in the original Medicare program. So there may be some cost savings there, but as Chris was mentioning, there are these limitations on specialists and on networks, so it's not a great deal for everybody.
As we will be doing throughout this program, we're now going to turn to our studio audience, made up of both health consumers and consumer advocates, for a question or comment about managed care. Our first questioner is Ramazi Jinjeet Hosh Vali, who is a Brooklyn resident. Your question, sir.
Okay, my question is about my father. He's on Medicaid and recently got a white envelope telling him that he has to choose a managed care plan. Okay, but he was recently diagnosed with tuberculosis. Okay, he is getting his treatment in a Victoria hospital, and we requested exemption forms, number 1 and number 4, but his primary doctor refused to sign the paper required forms. Okay, the question is, what can my client do to make sure that he doesn't have to join the managed care plan, health plan?
Right. Chris, what is your thoughts on this?
Well, it sounds like your father has Medicaid from prior to his diagnosis with tuberculosis, and I happen to have one of these envelopes, these white envelopes. And just for folks to know, there are two different kinds of envelopes that Medicaid beneficiaries are getting, a white one and a yellow one. If you get a white envelope, it means you're being asked to enroll in a managed care plan, and if you don't, as you know, you'll be assigned to one. There are a couple of exemption forms, as it sounds like you've tried already, one for chronic medical exemption if you have a chronic condition. But if your father hasn't had tuberculosis for 6 months or longer and been under the care of his physician for that time, he may not qualify for the exemption under that category. So it may be worth working with some advocates, and certainly the CSS program could try to advocate directly with the provider to find out what their resistance is, because managed care may not be the best course of treatment for your father.
Our second question comes from Harold Hirschlag, who's a volunteer at the Medicare Rights Center in Manhattan. Mr. Hirschlag?
As was stated, I am a hotline volunteer for the Medicare Rights Center. I would say that about 60% of the calls that I get have to do with people who just cannot afford the medication they're required to take. And I was wondering if there are any programs out there for such people so that they can be helped with their payments for their drugs.
Joe, I think
Well,
this is right in your field.
Sure. Fortunately, the EPIC program here in New York State was recently enhanced, and that program is for people 65 and older in the Medicare program. Basically, if people are living, single people are living with incomes under $35,000 a year, couples with under $50,000 a year, they qualify for the EPIC program, which is an prescription drug insurance program that's subsidized by New York State. You do pay some money out of pocket, but it's the greatest deal going for prescription drugs. Other than that, other states in the metropolitan region, if you're a resident there, they do have state-based programs that you can look into. As well, we mentioned earlier, some of the Medicare HMOs are providing limited prescription drug benefit. That may be appropriate. Given all the other limitations, it might not be appropriate. But right now, given some federal solution to prescription drugs, that's what's out there now for people 65 and over on Medicare.
Chris, do you have any further comments on that? Or?
Well, just to make sure that under the Medicaid program, people do know that drugs are covered and that, in fact, they are excluded from the Medicaid managed care plans. So you do need to keep your Medicaid card, and you use that to get your prescription drugs, which has been a real cause of confusion for people. So I just add that. Thanks.
For our next question, Sean Baker, who's a Harlem resident, is going to ask our panel.
My neighbor is on Medicaid, and he'll need to join a health plan soon. How should he go about joining the plan?
It's a
Chris?
really, thanks, jumping right in. It's a really complicated decision. There are 18 health plans right now serving the Medicaid population. So how do you make a choice among what at first blush looks like they're all the same? But in fact, they're not. And some of the first things to do are think about, where do you go for your health care now? Do you have a doctor? Do you have a hospital? Do you have some favorite places that you go to, and find out which plans they affiliate with? But that's not enough, because you also need to make sure that that hospital, that doctor, is accepting new patients under that plan. That's a place that I'd start, but I think it's also important to think about other issues, like if you have any ongoing health care needs, and how will the plan handle those? If you have any equipment that you use, if you have any treatment that you're used to getting, finding out from the plan how they'll continue that. So I would encourage them to do that, but again, not to promote our program, but we do that kind of counseling, and there is resources out there to help.
Joe, what happens if they're Medicare eligible? How would they go about the selection?
Well, a lot of what Chris has said applies to the Medicare program as well. So if you know people on Medicare that are looking for a Medicare HMO, they should think about all the same things. That advice about calling your doctor and making sure that he or she is in the plan and accepting new patients, I think, is key. I think the other thing is many people on Medicare are joining because of prescription drugs. And what they find when they enter the program, sometimes their particular drug isn't covered in that particular plan. So if you're entering in Medicare HMO to get drug coverage, call the HMO first and make sure that your drug is going to be covered. That way you know you've got that base covered. And you got to keep your ear to the ground, because these plans are always changing. They're leaving Medicare, they're coming into Medicare, they're adding benefits or adding costs. It's not a one-time deal. You've got to keep informed.
Our next questioner is Martina Pukta from the AIDS Service Center, Lower Manhattan. Ms. Pukta.
Hi. At the AIDS Service Center, I work with peer educators, most of whom are HIV positive. Now they're very concerned about these changes with managed care. So one of them came up to me recently and said she received one of those white envelopes that you were showing, and isn't sure at all what she has to do now. And another one actually spoke to me and said that they already enrolled her into an HMO, and she's very confused and concerned what she should do. Could you give them some advice?
Sure.
Chris?
First of all, it's important to know that although the city is beginning to require Medicaid beneficiaries to enroll, and if you get a white envelope, you'll be required, there are certain exceptions. And being HIV positive or having AIDS is an exception. You qualify for what's called an exemption. So for the person who received the white envelope, if they are HIV positive, the first thing that they should do is fill out one of these exemption forms, and it will require a doctor signing for them and affirming that they are HIV positive. The second thing to know is that if one of your clients has been enrolled without their knowledge, well, they qualify for being able to be disenrolled. They can get out of the plan, and they can get out of the plan on an expedited basis within 10 days, much shorter than the usual 30 days.
Chris, are there any other sort of specialized categories of people who need these kinds of exemptions? AIDS, obviously, is such a serious thing. Who else?
Yeah, there's about 10 different categories, and some of them are very fine. But in gross generalizations, definitely HIV, AIDS, but also people with chronic conditions who have been under the care of a provider for 6 months or more, and whose provider is not in a managed care plan. There's also exemptions for people who don't speak English and are receiving care from a provider who speaks their language and is also not in any managed care plan. So the language exemptions, the chronic medical exemption, and the HIV/AIDS exemption are some of the biggest category of exemptions.
To both my panel, this starts to get really difficult, particularly if you have language barriers or you're struggling with all sorts of life conditions. How are you finding it with your clients going forward, dealing with these kinds of complexities? White envelopes, and I mean, this gets really something.
Right. I mean, we don't have in Medicare the envelopes going out because in Medicare, of course, people aren't required to enroll in the Medicare HMOs. But we find a lot of people who are older, who might have problems with, their mental capacity or confusion or that sort of thing, really making the wrong decision for them. Fortunately, when we get involved, we can get them what's called retroactively disenrolled. As Chris was saying, we get them out of the plan very quickly and back into the government-run program. And if we can show that they basically were subject to some sort of sales tactic or they just did not know what was going on. But the problem is not everyone knows to call us. So when people hear about these things, if they can get in touch with us or through CSS, we can help.
Terrific. We'll be back to continue our discussion right after this.
You don't have to like me.
Or you can. You don't have to be my friend.
But you might like me if you got to know me.
You don't have to be my roommate.
I am gonna be your neighbor. You don't have to run with me.
You really don't have to run away from me.
You may not like what I have to say.
But hear me.
Hear me.
Hear me out. And we're not all that different. I like good food.
Good music.
I love my mom. Yeah, I want to fall in love.
Badly.
I want a good job.
I want my kids to live in a world
Where they are safe and loved.
And respected for who they are.
You don't have to like me. But if you talk to me,
You might.
we can end prejudice if we talk to each other.
Call.
Tell us what you do.
together we can build one America.
Welcome back to CSS Urban Agenda. I'm David R. Jones. Our topic in this first program of a special two-parter is managed health care. For our next question, we have a question from Radwan Dawood, the Center for the Independence of the Disabled of New York.
Thank you.
Dawood?
I have a question that I'm extremely concerned about. I need a motorized wheelchair and a personal care assistant to help me carry out my daily activities and keep my job. Will managed care help pay for these things the way Medicaid does now?
Chris?
Well, it's an excellent question. Right now, you're receiving Medicaid, and you don't have to join a managed care plan. If you're receiving Medicaid through SSI, you are not required, even if you do get one of these white envelopes, to join a managed care plan. But that may not last forever. As a matter of fact, in Westchester, folks receiving SSI are already being mandated into managed care. But it is important to know that home health care, personal attendants are carved out of managed care right now, and so you should continue to be able to receive them, even if you join a managed care plan. But it's going to be very important for us to keep advocating on people's behalf, on your own behalf, to make sure that you continue to get the services that you need.
Joe, do you have any further?
Well, once again, under the Medicare program, if you're eligible for both Medicare and Medicaid, you're not required to join a Medicare HMO, so you're probably better off staying with Medicaid and Medicare, the government-run programs for now, of course. In Medicare HMOs, they are required to give you everything that you get in Medicare, which would include motorized wheelchairs, home health care, if those are medically necessary for you. Basically, durable medical equipment in Medicare is covered as long as your doctor orders it, as long as it's medically necessary, and as long as you get it from a Medicare supplier, and that's the case in either managed care or the government-run program.
And there's no price cap. In other words, if he finds, he and his doctor decide on a wheelchair that happens to be more than a market, they haven't capped it or anything.
They haven't capped it. If they say that what you need is that more expensive model because that's what you need because of your medical condition, then Medicare will pay for that. Now, there may be higher out-of-pocket costs for you, but Medicare's fee schedule will go up with the cost of that equipment.
Thank you. Our next questioner is Alexandra Ramal, the Gay Men's Health Crisis. A comment, I think.
Yes, thank you very much. I work at GMHC, as you've said, and we frequently receive calls from people who have just been diagnosed with HIV. They are worried they might not be eligible for any insurance, or that they may have to pay more on down the road because their illness is so expensive to treat. What I tell them, and what people really need to remember, is that you're always eligible for insurance regardless of having a pre-existing condition in New York State. In particular, if you have had comprehensive insurance coverage and you haven't had a gap of greater than 63 days, and you change plans, your pre-existing condition will be covered. If there is a gap of greater than 63 days, then it'll take 12 months before they will start covering that particular condition. Anything that comes up during the new policy will be covered. One thing, it's important for people to remember, New York's a community-rated state, and so therefore you must be charged the same amount as other individuals are who are on that plan. I want to just sort of give out a phone number, 212-367-1125, which is a helpline which will answer any questions. Also, the New York State Department of Insurance has a phone number, and they even have a website for people to call to access with information.
Thank you very much for that information. Chris, by the way, in regard to some of these illnesses, certainly depression and mental health issues must emerge. What is the coverage on things like that? If you're dealing with life-threatening illnesses that are chronic, is mental health services under the managed care system, is that covered as well?
Managed care does not do as good a job with mental health services, but it is covered under Medicaid. And if you do have chronic mental health conditions, it's probably a good idea not to join a managed care plan if you can avoid it.
Our next question is from Valerie Thomas, the Citizens Advice Bureau.
I mostly work with seniors and clients with limited education. And I have a senior who has both Medicaid and Medicare. And she was enrolled in an HMO plan at an income support center. She was just basically told that she was eligible for the services. However, the client comes to the office 3 times a week to have her mail read and explained to her. And my question is, she went to her primary doctor because she wasn't really familiar with the services of an HMO, and she received bills for over $2,100. The managed care would not pay because it wasn't authorized. Medicaid would not pay because she was in the HMO. And my question is, can illiteracy be a factor to have a client disenrolled from an HMO?
Boy, Joe?
Well, in the Medicare program, and I assume it's the same in the Medicaid program, if she genuinely did not know what she was doing when she was signing up, either because she was, and a lot of older people have dementia or illiteracy or other sort of cognitive or other impairment, she did not know, then we can get her disenrolled and get her retroactively disenrolled, get her out of that HMO, and we can get either Medicaid or Medicare to pay those bills for her, because it's as if she was never in the HMO at all, because she shouldn't have been, because she didn't understand what was going on. So she sounds like a prime candidate for this disenrollment and for Medicaid to pay for her bills.
It's not only, of course, the question of people who have literacy problems. I mean, anyone who's been on the phone and told to touch, number 1 to get to number 2. Is this starting to come out? I heard informally from someone in a private HMO system of some cost cutting that was made by just delaying the time between, when you're put on hold with the music playing. That if you add 20 or 30 seconds to that, they can cut out certain people who just can't stay on the line. They're in the middle of their job, they just give up. Are we hearing any of these stories as we go ahead of people just, being totally, sort of stopped by the bureaucracy?
Absolutely. And you add to that the barriers of maybe not having a phone or language barriers and having to stay on the phone or find someone who not only will take the time to hear what your problem is, but then the time to resolve it. It's a really big issue, and one where I'm really glad that we have the opportunity to have this conversation, because if you don't know how your plan works, you won't become an effective advocate for yourself to make sure. You have to sometimes fight for the services that you need.
And how do the elderly take these tasks on? This becomes really something if you're an 86 or 90-year-old person, already having difficulty.
Well, exactly. I mean, many older people have just not chosen to join Medicare HMOs because they find it's too complicated or they can't get the care that they need. And this is one of the reasons we're seeing many of the Medicare HMOs criticized for having healthier clients than the government program. And so I think here, once again, I think people need to access our services and CSS's services in making sure that they're making an informed decision before they go into a Medicare HMO, because they might not get the answers they need from the HMO itself or from the salespeople or at the IS office or in other places, but we're here to help, and that's why we're doing this program.
We have another question from our audience, Christine Lawson from the United Jewish Organizations of Williamsburg.
Some of our clients are unhappy with the choice of doctors in their plan. Doctors in these communities often see many clients, and the consumers feel that their services are inadequate. Although New York Medicaid Choice does not consider this a good cause for disenrollment, what can the consumer do?
Chris, you want to take this up?
I'll certainly try and answer it, although I'm afraid my answer won't be satisfactory. There isn't a lot that you can do. We've known that the Medicaid program doesn't have enough doctors, and that in fact in many cases they're overloaded. And in order to disenroll, if you're required to join a managed care plan, you do have to have what's called good cause, and that's usually a medical cause, or if you've been coerced into joining, as the example that we heard before, there was some kind of consumer fraud. But in this case, it's really a question of getting services and knowing what the standards are. And in Medicaid managed care, there are some standards. You shouldn't have to wait more than 6 weeks to get an appointment. You shouldn't have to wait more than an hour to actually be seen. And when that doesn't happen, it's important to register complaints about that, both in the plan and out of the plan.
Joe?
Well, in the Medicare program, there are similar protections like that. The fortunate thing in the Medicare program is because managed care HMOs are not mandatory, you can move from HMO to HMO through this year on a monthly basis. Now that will change next year. There'll be more restrictions on going from HMO to HMO or from the government original Medicare program to an HMO. But right now, if you're unhappy in your HMO today, you can get out and you can go into the government program or to another HMO. So that's the way you can access other doctors very quickly. Although I wouldn't suggest that you do that on a frequent basis, because administratively it can become very mind-boggling very quickly.
No, I think there's been a lot of public discussion about either Medicaid and Medicare only kind of programs. I think people are closing down their Medicare operations,
yes.
And in New Jersey, I think we've all heard about a lot of this. What are we seeing? Is a Medicaid recipient going to have to be locked into a Medicaid only plan? Can a Medicare person who's doing just fine with their HMO find a plan actually that's reasonable? What's happening? I'll start with you, Joe.
Well, I think it is getting to the point where in many places, especially out on Long Island and Suffolk County and through the Hudson Valley, that people who once had Medicare HMOs available to them no longer do. We have about over 50,000 people this year who are being terminated from their Medicare HMOs. Now, fortunately, they always have the option to go back into the government-run original Medicare program. That's always going to be there. That's a bedrock. Right. And they have the chance to buy supplemental insurance, which is called Medigap. That's guaranteed to them under state law. So no matter how sick or how old they are, they can get those two programs. But of course, many want some of the goodies that they've been getting from the Medicare HMOs. And in many counties now, that is unavailable to them. There are Medicare HMOs available in the city and also out on the island, but not as great a choice. You really have to look carefully for those doctors and that drug coverage.
Chris, what about Medicaid only?
Well, in fact, we are seeing that almost all of the plans that are operating Medicaid and Child Health Plus programs are Medicaid-only plans, or Medicaid and CHIP, as we call the Child Health Plus program, only plans. And this is not the way it was supposed to be. The question earlier about doctors is an example. We thought Medicaid managed care would bring more doctors, new doctors, Oxford doctors and United Healthcare doctors into the system. And they started with us, and then they closed up shop. And we have to wonder whether the program can sustain and support the kind of care that it needs.
Thank you. My thanks to Chris Molnar and Joe Baker, and especially the members of our studio audience for joining me today. Tune in next month when we continue dissecting managed care with the help of both experts and consumers. Until then, I'm David R. Jones, and this has been The Urban Agenda.